Good morning, professors and colleagues. Thank you for joining me here online today. I am Safar Ali, postgraduate student, Dentistry of College Baghdad University, and I'm here today to present you my second seminar, which is about the furcation involvement. The furcally involved teeth, always representing unique challenge to the success of periodontal therapy. The treatment and long-term retention of molar teeth always have been a challenge to the general dentists and to the dental specialists because of their anatomically and morphologically characteristics. Those contents we're going to discuss in this seminar. Starting with a simple definition about the furcation. What is the furcation? It is the area of complex anatomic morphology located between roots of multi-root teeth, molars or premolars, making difficulty in removing a plaque in those areas, either with home care or with professional instrumentation. What is the furcation involvement? It's a general term or disease used to describe the bone loss, usually due to the periodontal disease affecting the base of the root trunk of a tooth where two or more roots meet. We have basic terminologies describing the root and the root furcation. Root complex means the distance from the cemento-enamel junction to the apex. It is divided into two parts. The first part is the undivided part, and the second part is the divided part. This is the root trunk, which is from the cemento-enamel junction to the entrance of the furcation, while the root cone is the separated part of the root complex. The fornix is the roof of the furcation, and the root furcation itself is the space between the roots. Degree of separation. It is the angle formed between the roots, and the divergence is the distance between them. Epidemiology. Different studies have shown that the furcation involvement most common in the first permanent molars, and a study by Rose and Thompson in 1980 found that the prevalence of furcation involvement in the maxillary molars was 90% compared to 35% in the mandibular molars. In the maxillary molars, the buccal aspects more commonly invaded, while the maxillary premolars, there's lower incidence of invasion. We have different reasons for the involvement of the furcation. Starting with the most important one, which is the long-term presence of bacterial plaque. As we all know, the bacterial plaque is the most common and the most important factor of periodontal diseases, including the furcation involvement. When it deposits on the tooth and it proceeds to the gingival tissue and then to the furcation, it will lead to the furcation involvement. Local factors including calculus, whatever, anatomic factors, iatrogenic factors, traumatic factors, always associated with furcation involvement. Dental caries, pulpal death, trauma from occlusion, and presence of enamel projections. Plaque-associated inflammation, I've just mentioned it. The accumulation of plaque resulting in the furcation involvement due to destruction of the supporting tissue of the tooth. Anatomical factors, including the cervical enamel projections, the root trunk length, root length and root form or shape, interradicular dimension, and the anatomy of the furcation. Cervical enamel projections, which is a local anatomical factor resulting in furcation involvement, described by Masters and Hoskins. They classified the projections into three grades. The first grade, according to the distance from cemento-enamel junction to the entrance. It extends from cemento-enamel junction of the tooth to the furcation entrance. While the grade 2 It reaches the entrance but not enter it, so there is no horizontal component. Grade 3, which is the advanced grade, it extends to the furcation, resulting in horizontal component, just like this picture. There is horizontal component, and here we have the enamel pearl, which is also an anatomical factor resulting in furcation involvement because it represents an area of difficult plaque control. Root trunk length. Teeth with short roots are more susceptible because the shorter the root trunk, the less the attachment need to be lost before the furcation invasion. Like here in the picture A, we have short root trunk, we have long roots here. So the support or the periodontium support only covering this part, and any invasion will result in rapid exposure of the furcation. Once the furcation is exposed, teeth with short root trunk may be more accessible to the maintenance procedures, and the short root trunk may facilitate some surgical procedures. This is an advantage when it's involved or when it's exposed, because it will represent an easily approached surgical procedure and easily easily to be maintained clean by the patient. So the short root trunks may facilitate some surgical procedures, as I mentioned, and alternatively, teeth with usually long root trunks or fused roots are not appropriate candidate for treatments once the furcation has been affected. Just like here in this premolar, we can see the root trunk is very long and the root cone very short. So once this involved, it will be very difficult to maintain the surgical procedure outcomes or maintain the area clean by the patient. The root length. Root length is directly related to the quantity of attachment supporting the tooth. Teeth with long root trunks and short roots may have lost a majority of their support by the time that furcation becomes affected, while teeth with long roots and short to moderate root trunk are more readily retreated because sufficient attachment remains to meet the functional demand. Root form. Presence of flutings on the root surface, coupled with developmental grooves, and concavities, plaque retentive areas hastening the process of periodontal breakdown, leading to early furcation involvement. Presence of fluting like here or concavities on the root representing areas of plaque retention. So it will both result in early and rapid exposure and difficult to be maintained clean. Anatomy of the furcation. Bifurcational ridges like this. Concavities in the root and accessory canals may jeopardize the plaque control as well as treatment outcomes. Is another anatomical factor. The interradicular dimension, whether it's wide, narrow, or roots may be fused. The degree of separation of roots is also an important factor in the treatment planning. Closely approximated or fused root like this can preclude the adequate instrumentation during scaling. Root planing and surgery. Teeth with widely separated roots like this, presenting more treatment options and more readily to be treated. Trauma from occlusion. We have different concepts explaining the association between the trauma from occlusion and the furcation involvement. According to Glickman et al. In 1961, he reported that furcations are some of more susceptible areas of the periodontium to excessive occlusal forces and load, and suggested that the periodontal fiber's orientation in the furcation area facilitating a more rapid spread of inflammation and accounted for the increased susceptibility to occlusal load. According to Glickman, the orientation of the fibers, like the interradicular fibers, horizontal fibers, alveolar crest fibers, supporting the furcation area, associated with more rapid spread of inflammation to that area. Well, according to Linda and Svenberg in 1974, they stated that trauma from occlusion coupled with gingival inflammation has been implicated for a greater alveolar bone loss in the experimental animals. The heavy occlusal load in molar teeth may render them susceptible to increased bone loss in the furcation if inflammation is present, which means that when we already have inflammation, but with the presence of the occlusal forces, together can result in the furcation involvement. According to Werhog in 1980, he suggested that the increased mobility in the late symptom is only a late symptom rather than a cause of the furcation defect. So he didn't give attention for the factor of trauma from occlusion in the presence of furcation involvement. Clinical features. Tooth may or may not be mobile, and it could be associated with the following symptoms. First, it could be sensitivity to thermal changes caused by caries or resorption of root in the furcation area. There could be recurrent or constant throbbing pain caused by pulpal changes, sensitivity to percussion caused by acute inflammatory involvement of the periodontal ligament, acute periodontal or periapical abscess formation. Those symptoms may or may not be present, and it's not important for all those symptoms to be present. Classification. Classification of the furcation involvement are too many, and it could be over 20 classification. Here in this seminar, I chose those 3 basic categories to choose the mostly used classifications and easily to be kept. First, based on the horizontal attachment loss, second, based on horizontal and vertical component, and third, based on combination of these findings and morphology of bone deformity. Based on the horizontal attachment loss, I chose the Glickman classification in 1953 and Hamp's classification in 1975, while based on the horizontal and vertical components together, Turnau and Fletcher's classification in 1984, and that based on combination of these findings and morphology of bone deformity, Isley and Drennan's classification in 1969. According to Glickman, we have 4 grades, 1, 2, 3, and 4. Grade 1 is the incipient lesion, suprabony pocket with slight bone loss in the furcation area. Picture here is chosen from a cadaver because it's not obvious clinically. Grade 2 is the cul-de-sac. Cul-de-sac means blind and tunnel, or tunnel with one end open, one end closed. Loss of interradicular bone and pocket formation, but a portion of the alveolar bone and periodontal ligament remains intact, which means on probing, we can enter the probe from one end, but cannot get it from the other end. Grade 3 is the through and through lesion, where we can see complete loss of interradicular bone, and it's called through and through because when we are making probing, we can get the probe end from the other side. Grade 3 is like the grade 4 is like the grade 3, but it differs in that there is a gingival recision, so it's very obvious clinically. Humps in 1975 made another classification. Degree 1, there is a horizontal attachment loss, but it's less than 3 mm. While in the grade 2, there is attachment loss horizontal attachment loss more than 3 mm, or more than 2/3 of the furcation width. Grade 3 always through and through. According to Turner and Fletcher, who combined the horizontal both with vertical loss, for each of the previous classes of the horizontal classification, they added subclasses called A, B, and C. Subclass A is the vertical loss. Grade A 1 to 3 mm, while grade B is 4 to 6 mm, grade C 7 or more mm. So according to this, we will have furcation would thus be classified as 1A, 1B, 1C, 2A, 2B, 2C, and 3A, 3B, and 3C. Here are another pictures showing class 1. As we said, it's less than 3. Class 2 more than 3. 3 or more than 3. Class 3 through and through. Isley and Drennan suggest another classification. According to them, class 1 will be the incipient involvement, but there is no horizontal component to the furca. In class 2, they added type 1 and type 2 to this classification. The type 1, presence of horizontal attachment loss into the furcation, but there is no vertical component. Class 2 type 2 means the presence of horizontal bone loss and the vertical bone loss together. Class 3 type 1, through and through attachment loss into the furcation with no vertical component, while class 3 type 2, through and through bone loss with vertical component. Another proposed classification systems for furcation involvement. Here we have non-exposed and exposed, and each of them categorized into 3 subclasses. The non-exposed type 1 means the furcation lesion is not clinically exposed, but there is a horizontal attachment loss, which is 2 mm or less. Let's discuss those classifications. Non-exposed type 1 or non-exposed class 1. Here in the first mandibular molar, we can see here on probing there is a buccal furcation lesion and horizontal attachment loss of 2 mm. So we cannot see the furcation, but on probing we can see initial exposure of the furcation. Here also non-exposed furcation lesion, class 2. On the second molar here we can see on the buccal aspect. On probing we cannot see the furcation in this picture, but on probing we found 4 mm loss, horizontal attachment loss. Non-exposed furcation type 3. On the first mandibular molar here we can see the total horizontal attachment loss, which is through and through. On probing we discovered it. The second classification is the exposed furcation, class 1. Here we have exposure of the furcation clinically, but on probing we can see here it's 1 or less millimeter attachment loss. Exposed furcation lesion, class 2. First maxillary molar, here we can see the furcation is visible clinically and the attachment loss is only 4 mm. Non-exposed type 3, first mandibular molar here, total horizontal attachment loss, and there's through and through. So it's post-exposed, and on probing or when we insert any instrument, we can see a through and through. However, There is no one classification that is accepted and followed universally. So, we always choose the one that is suitable for the case we are treating and the one that we can keep easily. Diagnosis and measurements. The diagnosis depends on the furcation probing as a first step. We have some facts here we're going to discuss. Maxillary molar has 3 furcations because it has 3 roots: the buccal furcation, mesial furcation, and distal furcation. Buccal furcation can be probed buccally, while the mesial furcation is more located palatally, so we are probing it from the palatal aspect. Distal furcation easily probed distally. Molar, when it's multi-rooted, it has buccal and lingual or palatal roots, so it has 2 furcation, the mesial and distal. Mesial furcation detected mesially and distal furcation detected distally. Mandibular molar has 2 furcations and 2 roots, the mesial and distal roots, so it detected lingually and buccally. Measurement techniques. Using straight probes like the UNC probe to detect the vertical pocket depth. Here the probe is inserted into the periodontal pocket along the root surface to locate the initial fluting of the furcation. Once it's detected, then the distance from the gingival margin to the opening of the furcation is noted. Then the probe advances more apically until resistance is felt. Then the distance from the gingival margin to the vertical depth of the probing is noted. The vertical pocket depth of the furcation is recorded to the nearest millimeter as the difference between the 2 values. Similarly, the horizontal pocket depth can also be detected, either by using the intersection of 2 periodontal probes or rubber stopper placed on the periodontal probe acting as a reference point for depth penetration. Like here in this picture, the first probe is inserted into the furcation until the horizontal depth is reached, followed by the placement of a second probe held against the furcation, such that the point of intersection of the 2 probes indicates the depth of the horizontal component of the defect. The second way is by using the stopper. The disadvantage of this method is that with this technique, holding the reference probing at exactly the same point and the point of probe intersection is not easily reproducible, especially in the posterior regions of the mouth. And also the disadvantage of the drawbacks of the stopper. First is the presence of soft tissue covering the furcation fluting that interfere with visualization, and this technique also has a lower reliability when used for measurement of distal lingual furcations due to the impossibility of direct vision and difficulties in probing in this remote location. Probing difficulties. The same difficulties we are facing when we are making probing, including the penetration of the probe, the force we use, tip diameter of the instrument, the tissue quality and presence of inflammation, the angulation of probing, presence of calculus, and overhanging restorations. These limiting factors in turn affect the reliability and reproducibility of the measurements. The type of probe used is another factor affecting the recording of accurate values comparing to neighbors that we are going to discuss in the next slides. Studies confirm that the various clinical methods of furcation evaluation by probing provide only an arbitrary clue to the severity of furcation involvement. that the chances of misinterpreting the values remain high because of the inherent limitation of the probes we already discussed. Neighbor as a probe comes in different types. Type 1 or 1N neighbor. It comes with smooth, non-calibrated surface and sharper, more defined curves, angles. Used for measuring mesial and distal furcations on the maxillary molars. The second type, 2N or neighbors 2N, it also smooth and non-calibrated surface, but there is a shallower curve at the working end and decreases and accesses all buccal and lingual furcations. The third type is the neighbors Q2N. Here it is color-coded, and the color coding at the 3, 6, and 9, 12 millimeter. The ACE furcation probe, this one, feature a straighter furcation probe design to ensure patient comfort and flexible enough to reach the most difficult furcations. The furcation end is etched with 3, 6, 9, 12 markings like neighbors. The probe can be used for pocket probing as well as probing the furcations. Bone sounding. This method is a transgingival probing technique that is used under anesthesia because it's painful, to plot the morphological outline of the furcation defect, because the furcation bone sounding giving consistent measurements that are equivalent to open bone measurements, and in addition avoids a re-entry procedure, so it can be considered as the good substitute for open bone measurements. Another way is the open bone measurements. With the probes following the reflection of the facial and lingual flaps, we can make the open measurements. And the debridement of the defect area, vertical attachment level can be made to the nearest millimeter of the UNC 15 probe, from the furcation fluting to the base of the defect. Radiographs. Traditionally, as we all know, radiograph assessment in conjunction with clinical probing have been the chief diagnostic method for detecting and characterizing furcation involvement. If radiographs are taken properly, processed properly, good angulation during exposure of the X-ray beam, then we can use it as a valuable supplementary tool in the periodontal disease diagnosis to reveal the morphologic characteristic of the alveolar bone. It should include both intraoral periapical and vertical bite wing radiographs. Shortcomings in the traditional radiographs, as we always say, it depends on how well the image is taken and processed. Since it's 2D, then the overlap of the surrounding structures can occur, masking the details. Also, an ability to detect initial alveolar changes is common. In these radiographical pictures, we can see the shape of the normal furcation, which here the bone is nicely filling the furcation. This one could be class 1 or 2. Here we can see a shadow, a black shadow, surrounding the furcation. Here, completely black triangle means we have through and through furcation involvement and complete loss of interradicular bone.